in their lives. So the good thing is there have been a lot of programs over the past 2 decades that have tried to understand what is really associated with the biology of aging, what is physical resilience, how do we identify this, and how do we try to offer our patients the best possible care. One of the first studies, which came out in 2007, is from England. It's called the POP study, the Proactive Care of Older Persons Undergoing Surgery. And in this study, the investigators looked at all the possible trigger factors that could make a surgeon or an anesthesiologist work together as a team to try to improve care of the patient prior to surgery. As you can see, uncontrolled hypertension, recent MIs, unstable angina, heart failure, prior strokes, patients who have significant COPD, medications, and then problems with the patients themselves, poor nutrition, a history of falls, problems with cognition, and in a need for assistance even in their activities of daily living.
Dr. Lagoo, sorry for the interruption, but just wanted to let you know that your slide presentation is not following the outline that you have. I'm sorry.
Okay, hold on. I'll just stop this and I'll share it one more time. Thank you. Is this showing you what's the evidence? The POP
Yes,
study?
that is correct.
Okay.
It's funny. I thought it was only me.
No, thank you for saying that, Kurosh. Appreciate it. So what they did find was with this amount of proactive care in the older person, they were able to reduce the number of complications that these patients had. And they saw a reduction in pneumonia, in delirium, pressure sores, pain control, delayed mobilization, and prolonged catheter use, and also a decrease in their length of stay. So this was very good in trying to explain why something needed to be done for this frail patient population. We did the same study here starting in 2011. And the study that we had, the program that we started was the Peri-Operative Optimization of Senior Health. It was an interdisciplinary program and involved the surgeons, the geriatricians, the anesthesiologists, social workers, physical therapists, and occupational therapists, and the nutritionist. We took care of all patients who were over 80 years of age, or those who were between 65 and 80 years of age who had certain trigger factors or certain vulnerabilities. It was an interdisciplinary preoperative clinic, as I mentioned, and the most important thing was that it was the surgeon who decided that his or her patient needed to be seen in the POSH clinic. And this perioperative care team continued to take care of the patients after surgery so that there was a continuity of care. And that aspect was mostly taken care of by our geriatricians, who had a co-management team with the surgery team. So what were we able to show? We were able to show a decrease in the medial length of stay between the control and the POSH group. And the control was a historical control that included patients in the 18 months prior to initiation of the POSH program. We were also able to show that whether the patients underwent laparoscopic procedures or open procedures, there was still a decrease in the median length of stay. Readmissions at 7 and 30 days were decreased significantly. And then 30-day readmission by procedure again showed the same benefit in both laparoscopic as well as in open procedures. The other important thing was the discharge disposition. And this was very critical because most of our patients went home with self-care rather than home with home health or to a facility or to hospice. And Dr. Shelley McDonald was the geriatrician who was there from its very inception in 2011 and is currently the medical director of the POSH clinic. And the surgery director of the POSH clinic has been newly appointed, and it's actually one of yours. It's Dr. Russell Kamke, who is an ENT surgeon at Duke University, and we're really very happy to have him on board. So the next study that I want to talk about is the study that was performed in Michigan. It was called MSHOP, which is the Michigan Surgical and Health Optimization Program. And this was a very beautiful study by Dr. Howard that was published in 2019. They had a preoperative prehabilitation program, and they had 4 activities that they concentrated on prior to surgery: physical activity, pulmonary rehab, nutritional optimization, and stress reduction. And this was in patients who were undergoing colectomies. They were able to show a decreased morbidity as well as mortality in patients who went through the MSHOP program compared to those who did not go through the MSHOP program, both in the elective as well as in the emergent group. They were also able to show that overall hospital charges was much less in the MSHOP group, and that was obviously because the complications and the length of stay were much better within the MSHOP group than in the non-MSHOP elective and emergency surgical procedures. So these have been excellent studies, and in 2015, the American College of Surgeons decided to start the process of creating a geriatric surgery verification program. It was called the Coalition for Quality in Geriatric Surgery and was funded by the American College of Surgeons as well as the John A. Hartford Foundation. And they talked about various aspects, but the 4 main pillars during this entire initiative was to concentrate on goals and decision-making in the older adult, to concentrate on their cognition, their function, and nutrition and hydration. So those were the most important pillars. They also published the Optimal Resources Guide for Geriatric Surgery, and I will go into that in just a minute. But the important thing was, this was throughout the arc of surgery. So it started with the discussion in clinic, the preoperative optimization, the immediate pre- and intraoperative period, the postoperative period, and then very critical to good care, transitions in care. So the Optimal Resources is a great guideline, and this is online and anybody can access it. It talks about what all is needed to participate in this program: institutional administrative commitment, the governance of the program, all the resources that you need. And Dr. Parham will be discussing this when he talks about geriatric surgery resources. So that is going to be extremely useful. Patient care, expectations and protocols, data surveillance systems, quality improvement projects while you are carrying out this mission, and then professional and community outreach, as well as information about any trials. So there were 9 standard chapters, and they covered, as I mentioned, the standard title, the definition and requirement of what is needed, documentation of how after you do something, it is actually documented. And the reason being that the American College of Surgeons would then conduct a site visit to say, yes, you have done everything that you were supposed to do, and they can then verify you as a geriatric surgery center of excellence. And why is this important? It's important for patients and caregivers because you do focus on goals of care. And this is important because sometimes after a major discussion with patients and family members, they may change their minds if they feel that their goals are not in alignment with what you are going to offer them. Increased attention to optimization. For the providers, this is great standardization so that we make sure that every patient gets the same care every single time. And for the hospital, of course, a decreased length of stay, decreased healthcare utilization costs, decreased complications suggests that they are able to offer good care. The American College wants this program to be adopted by every hospital. And so this is not a program that is only meant for tertiary care hospitals or only for academic hospitals. It is for every hospital, so that if you're operating on a person who is over the age of 75, and for the GSV program, just to make it easy for everybody, it's 75 years and above, you should be able to offer them good care. And so what are the different levels of participation? The non-verification program part of it is called a commitment level, which means you let them know that you're going to be participating, you put in an application, they make sure that you have everything in place to be able to start at the commitment level, and you can be at a commitment level for a maximum of 2 years. If at the end of 2 years, you're not able to go to a level 2, which is the next step, or the level 1, which is the highest step of excellence, then you have to bow out of the program. So I'm going to start from the bottom up. The GSV commitment level is has been developed to address the institutional resources and their readiness by providing all hospitals the opportunity to improve surgical care. So the ACS shares educational material and gives you access to other hospitals that are participating, and they have monthly discussions about how you are doing, what problems you're running into, and how they can help you. For level 2, which is focused excellence, they want it to be that up to 50% of the patients are going to be within this program. So you can decide that it is going to be among certain specialties, general surgery, vascular, and ENT, for example. And it is these patients for whom you will be making sure that all the standards are followed. And level 1 is where it is for greater than 50% of the patients. So more services being involved in this particular initiative. There is a cost to this. So the commitment level is $2,500 a year. The level 1 and level 2, which are the focused or comprehensive excellence, are $7,500 annually for rural institutions and for federal institutions. And then for others, it is $15,000 annually. The target audience, as I mentioned, is almost about the 5,000 hospitals that we currently have. All hospitals, community, teaching, non-teaching, and academic. And the concentration is going to be on those who are 75 and older. And so, as I mentioned, there are different services, and you can decide which services you're going to start with, and then you can roll it out to the entire hospital. So I'm going to be very brief about this, but I just wanted to let you know that one of the important things is people ask you about why is it that you're carrying out an initiative like this, and where is it going to help? And is there any one complication where this type of a program can make a difference? And I know that Dr. Eibling will be talking about this, so I'm not going to go into great details, but it is very easy to try to think of delirium as a starting point to show how this type of a program can help to reduce the incidence of delirium because of better recognition and treatment of delirium, and how this can actually save the hospital a lot of money. So this was a very beautiful recent paper earlier this year that talked about the 1-year Medicare costs associated with delirium. And you can see that in patients where there was only mild to no delirium, the hospital cost was about $62,000 for that particular index hospitalization. It goes up to $66,000 if it is a case of moderate delirium, and then goes up to $90,000 if it is severe delirium. Not only that, when you look at the time after discharge, you can see at the very bottom the period-specific costs. If discharge is anywhere up to 30 days, there is an increase of $6,384 because of that. In a person with no or mild delirium, that goes out to about $10,000 for those who have moderate delirium, and so on. So obviously, delirium results in a lot of expenditure to take care of the complications and the increased length of stay that occurs with delirium. The other thing that you can look at is what is important when you're looking at delirium. And one of the things that we tried to study was what is the effect of cognition in patients who are over 65 years of age and having surgery, and who are taken through a preoperative optimization program. So the main difference that we found here was that 80% of patients who had no cognitive impairment were able to be discharged home, whereas only 65% of patients who had cognitive impairment could be discharged home. Again, a very important factor to consider when you think of the increased incidence of delirium in these patients. The reason that we felt that most of the other factors did not show as much of a difference was because in these patient populations, those who had cognitive impairment were being followed very closely by the POSH team and the geriatricians. They were able to diagnose the delirium as soon as possible, and they were able to treat these patients. So obviously an optimization program has benefits. This was another paper showing how Medicare spending can be slowed by Dr. Rinaldo, and showed 3 important factors that could cause increased complications in the postoperative period. One was social isolation, the other was functional decline, and the third was misaligned end-of-life care. And all of these issues are actually being addressed when you think of a geriatric surgery verification program. And there is, of course, they could not show us any cost savings because of the social isolation, but they could definitely show savings with prevention of functional decline and prevention of misaligned end-of-life care. And so the high values and the things that we can do to make a difference are to challenge this problem of social isolation by having the community be involved with patient care. And we do this a lot when we talk about preoperative optimization, trying to get patients to involve their family members or their neighbors or friends, and sometimes their church or other group institutions of faith to help them through this difficult period. We definitely address the issues with independence and physical resilience and communication, trying to make sure that we talk to them before surgery about their goals, make sure that we are always addressing areas that improve patient satisfaction. So I think I have hopefully provided you with the reason why we should take care of our older adults a little differently and concentrate on issues that result in frailty. How we can do this by preoperative optimization initiatives, and every institution has their own. It's just good to do it on a consistent basis. And then we've talked about how it can help the hospital systems themselves. Can you do it at your institution? I think you can, because the 4 quadrants that I show you in the right upper quadrant are the main quadrants that the GSV talks about: patients, family and caregivers, providers, and the health system. And it is in fact important to have patient and family representatives, which I'm sure you all have, a strong surgical program, a multidisciplinary program that works as a perioperative team with the surgeons and helps them in care of the older surgical adult. Hospital performance services to give you the data that you need to see how you're doing, to see if you're actually seeing improvement. And then most importantly, buy-in from hospital leadership. And the reason I showed you how much of a cost savings all of these initiatives can lead to is because that is what the hospital leadership always wants to know. What is their return on the investment? And I think that will help you to try to make a good case when you meet with them. And so to conclude, I think having a geriatric surgery program is really very useful for the patients, for the providers, and definitely for the hospital system. And I will let Dr. Eibling talk about delirium reduction, because I think that is something that you will be able to take to the hospital leadership to talk about the return on investment. So thank you all very much for your time.
Thank you, Dr. Lagoo. That was an excellent overview of the importance and the elements that are required for a formal program. So now we'll take it down one step to talk about the resources that are probably available to most of you, even if you do not have such a formal program in place. Dr. Parham?
Thank you, Dr. Puscas, for the organization of this fantastic panel, and it's an honor to be here, particularly with this distinguished panel. That was a wonderful introduction, Dr. Lagoo. Thank you so much. I'm going to just give you a brief overview, a very quick overview of some of the resources that are available to surgeons and at the institutional level, which the surgeons can advocate for to promote geriatric surgery and improving with the goal of improving outcomes.
Dr. Parham, you accidentally muted yourself.
Forgive me, I'm going to suffer these mishaps often, so don't hesitate to interrupt and let me know. Thank you. So I've broadly broken down this presentation into resources that are available to the surgeon and resources that are available to the institution. And in terms of the surgeon resources, we're very fortunate to be beneficiaries of the collaboration between American College of Surgeons and American Geriatric Society. And they have published a number of resources that are readily available, including the preoperative and perioperative guidelines that are out there. Of course, Dr. Tulunay-Ugur is going to go over the preoperative recommendations, so I won't dive into that very deeply. And Dr. Eibling will talk about cognition. So again, I'll just touch on these topics. Then I'd like to go over some new innovations in terms of shared decision-making model in high-stakes scenarios, which is referred to as best case, worst case model. This is basically for obtaining informed consent in the geriatric setting. Then we'll talk about some institutional resources. And again, I'll briefly mention the presentation, the Geriatric Surgery Verification Program that Dr. Lagoo just thoroughly and very well described, and then talk about a couple of other models that are out there, including American Geriatric Surgery's Hospital Elder Life Program. So again, we really have to give a nod of acknowledgement to American College of Surgeons and American Geriatric Society for their effort that has been ongoing, and it's been a fantastic partnership. But a big thanks to the John A. Hartford Foundation, who put the financial resources at the disposal of these fine organizations to propel this whole initiative forward. Without that support, none of these programs would have really materialized, despite the best wishes of many people around the country and around the world. Obviously, the latest product was what Dr. Lagoo just described, the American College of Surgeons Geriatric Surgery Verification Program. But the couple of others that came out over the past decade include the best practice guidelines on perioperative assessment of the geriatric surgical patient that came out in 2012. And then that was followed in 2016 by optimal perioperative management, sort of broadening the scope. And these are all part of the now familiar NSQIP program, the Quality Improvement Program of the American College of Surgeons. And, you know, when we think about geriatric surgery, and oftentimes the question is, well, what's really different about geriatric surgery than regular adult surgery? And a long time ago, of course, this question was answered in terms of pediatric surgery, but the question of what's different about geriatric surgery still lingers. And when we look at the perioperative guidelines that came out, or preoperative guidelines that came out in 2012, I think really it highlights the focus. And it's really on the cognitive ability of the patient that we're dealing with. Cognitive ability not only after the operation, but also importantly, where it stands before the operation. So the guidelines that have come out so far have heavily advocated assessment of cognitive ability and capacity to understand the anticipated issues that a patient may experience around the time of surgery. And as you know, postoperative cognitive dysfunction is very common in the postoperative phase in our older patients, and it's been described to occur in up to 65% of the patients after general anesthesia and surgery. Again, I'm not going to dive into this too far because Dr. Eibling has a fantastic presentation coming up. But by cognitive dysfunction, we're including delirium, which is a big one, but also beyond that, neurocognitive disorders and delayed neurocognitive recovery also have to be kept in mind. There are, of course, known risk factors, and there are precipitating and predisposing factors. Among the predisposing factors, naturally advanced age is the most prominent, but pre-existing cognitive impairment is another big factor to keep in mind. There are certainly precipitating factors such as the invasiveness of the surgery, and the duration of the operation, among others that need to be noted. In terms of cognition and preoperative screening, the American College of Surgeons National Surgical Quality Improvement Program and American Geriatric Surgery's Best Practice Guidelines both recommend assessing cognitive ability of the geriatric patient preoperatively to quantify what their risks are and have something to compare to after surgery, after the event has taken place. They advocated that, anybody 65 and older deserves this kind of screening. The question that comes out from many surgeons that I have talked to is, well, how am I going to integrate such a cognitive screen into my busy practice? There simply is no time for that. And let's say I do that, then how do I apply that screen data to the perioperative management? Well, let's just review what are the assessment tools that are available out there in terms of preoperative screening. And the traditional assessment tools have included the clock drawing, the traditional clock face drawing, the 3-word memory test, counting backwards from 100 by 7, spelling the word world backwards. Individually, all of these by themselves really don't take a whole lot of time. And certainly they have been put together in various screening kits to improve reliability of the tests. And I've named a few over here: the mini mental status exam, the MiniCog, the Montreal Cognitive Assessment Tool, and others. And these are, when evaluated objectively, do assess cognition on multiple domains, including attention and concentration, executive function, and so forth. So they're very effective. But there are downsides to certain tests. For example, the mini mental status exam, despite its name, it still takes about 10 minutes to complete. It assigns points depending on the responses, and there are a range of questions that are asked that are designed to assess orientation to time, place, memory, testing attention, and so forth. And it's a proprietary test, meaning that the rights belong to the psychological assessment resources. On the other hand, just cut to the chase, when American College of Surgeons and American Geriatric Society published their guidelines, they advocated for the use of the MiniCog, and MiniCog really has 2 elements. That's it, the 3-item recall. So you just basically name 3 words: banana, sunrise, chair, ask the patient to repeat them. They acknowledge having heard them, and then you invite them to draw the clock face, give them about 3 minutes, and then ask them to repeat the 3 words, and then you simply assign a point scale to their performance, and that scale guides you on whether the individual is at risk of impairment, has an existing impairment, or has no impairment. And once a patient is identified, the recommendation is to seek assistance from multidisciplinary care involving geriatricians if they are available, and if not, working with primary care providers who have some expertise in geriatric care to try to optimize conditions prior to proceeding with surgery when that luxury exists. So why bother again? I mean, postoperative cognition discussion is common, but the challenge is that it's difficult to quantify in some patients post-surgically, and it's even more difficult if you don't have a baseline measure to compare it to. So the pre and post-op assessments are essential in order to stay on top of it. And of course, the preoperative assessment also informs you on the decision-making capacity of the patient. Is this patient able to provide informed consent? That's a critical question in the geriatric setting. Speaking of informed consent, another resource that I want to share with you, and it's something that's now getting greater recognition, is promoting a new communication framework when it comes to time to discuss surgery in the geriatric patient. And this shared decision-making model has been promoted and heavily worked on using evidence-based by Dr. Gretchen Schwartz at University of Wisconsin. She's a vascular surgeon. And she advocates for going beyond the risk disclosure language of the informed consent. And the traditional informed consent gives percentages and provides a list of problems that could occur. And what she advocates for is promoting dialogue and deliberation between the patient and the surgeon about the value of surgery. And this has to be placed in the context of patients' individual values and preferences. The way it's done is done by a surgeon trying to help the patient visualize the range of possible outcomes, and then illustrates that some outcomes are more likely than others, to convey the choices that are available to them, rather than the traditional approach of presenting the dominant plan and then some secondary alternatives. So it begins by presenting the bad news, the need for surgery, of course, identifying the treatment choices, and it's usually surgery versus medical management, or major surgery versus lesser surgery, surgery versus supportive care, or all of those options in one sitting can be compared. And then we go through this the best case, worst case illustration. So for example, for the best case, those are illustrated in this diagram where surgery is being compared to an alternative. The best case is shown at the top, worst case scenario is at the bottom. There's a continuum that connects those two endpoints. And basically, when discussing the best case, you provide the tangible long-term outcome of the proposed treatment. Talk about short-term implications, including the proposed treatment and the short and long-term recovery. What's it going to take? Is it going to be a stay in the ICU after discharge from how long one is going to be in the hospital, likely, and will the individual need skilled nurse facilities after discharge? All of those factors have to be taken into consideration. And basically, you want to make sure that illustrate to the patient what this looks like in the larger context of patient's overall health. You know, we want to discuss the surgery in the context of their current chronic issues, and/or if there's terminal illness involved, and the likelihood of the outcome being realized, the best case outcomes. In terms of the worst case outcomes, again, you want to provide reasonable long-term outcomes, describe what happens between now and the possible worst long-term outcome, and don't just concentrate on death as being the worst outcome. Most geriatric patients, when they express their fears surrounding surgery, actually identify the uncertainty of being in the ICU and how long they're going to be in there and potential demise in that setting, rather than immediately in this surgical scenario itself in the surgical operating room. So by basically laying out this scheme, then you identify in each of these two alternatives what the patient, where the patient is likely to be along this continuum by sort of drawing a circle and allowing the patient to sort of get an idea of, through the schematic of where they stand in these two conditions that are outlined. There is no need to use percentages. After all, we're still accumulating data in the geriatric settings. Percentages that apply to average adults don't necessarily apply to individuals with multiple comorbidities and concerned with frailty and cognitive decline and so forth. So there might not be any outcome between best and worst case scenario. And if that's the case, that should also be acknowledged. That is a limitation of this design, but it is appropriate to, this is an appropriate means of communicating the alternatives available and potential outcomes to the patient. So just the broader scheme. So the initial goal is to identify the choices available. Next, laying out best case, worst case scenarios. Then you engage the individual in a question, forgive me, in questions and deliberations, and answer their questions, identify their fears, and then the surgeon is asked to actually recommend communications once all the, provide a recommendation regarding which option the surgeon recommends. And that's very important to emphasize that in the older models, I oftentimes provided the options to my patients and then stepped back and allowed them to make a decision. Dr. Schwartz heavily advocates for the surgeon not to cop out, and I'm using her words, not to cop out. The surgeon is the one with the expertise and the insight to be able to make a sound recommendation to the patient and then arrive at a shared decision. And if the patient chooses to proceed, then informed consent is obtained. So now I want to just go over a few institutional resources and other kits that are available. And among them are, briefly to mention, just Geriatric Workforce Enhancement Program. This is the 4 M's of age-friendly health systems that are taken into account. And really, it's a resource-based approach concentrating on the 4 M's framework on age-friendly health systems, and it's been advocated by a number of organizations, including American Geriatric Society, and by the 4 M's. I'm talking about focusing on acting on what matters, basically honoring older patient's choice, taking into account polypharmacy or medication, emphasizing importance of mobility, and certainly mentation. And these toolkits are available through, this one is particularly available through American Geriatric Society, and there's a lot more to it than this one slide can capture, but just to name one of the many that are out there for you. And of course, Dr. Lagoo made a fantastic presentation on the geriatric surgery verification program. And as an observer, I can tell you how hard Dr. Lagoo and her partners worked on this. That was a several-year effort. And they engaged many stakeholders. The 58 stakeholders were brought in for input. And I was there as an observer, as a stakeholder representing American Academy of Otolaryngology. And I can tell you that they started with 300 standards and then whittled that down in a painstaking fashion down to 30 practical standards. And so this has been well thought out. It's been driven by evidence-based, and it is going to be a game changer in terms of quality improvement for geriatric surgery. I'm not gonna, she did a fantastic job, so I'll skip to the next model. And I'm mentioning these next couple of models as lessons for our community, otolaryngologist community. We're kind of way behind other specialties in our efforts to promote geriatric quality in our outcomes. For example, consider the geriatric emergency medicine accreditation programs, and currently there are 228 hospitals participating. And they have shown through participation through this program that risks of admissions into the hospital, readmissions into the hospital, are reduced by nearly 20%. And there's been significant cost savings from $2,000 to $3,000 per patient simply by the emergency room participating in this program. And the reason that this is important is because it goes along with the studies that Dr. Lagoo talked about, the POP study, the Duke-Posh study. They're all pointing to advocating for proactive care of the geriatric patient through multidisciplinary care. So everybody who comes in contact with that patient has a role to play, and they all need to be working in concert with each other. And that's why it's so important to take it from the starting point. In this case, the geriatric emergency medicine certified programs and departments. And here's another successful model that exists. The American Geriatric Society's Co-Care Ortho. And this again advocates for earlier timeline from making decisions, going towards surgery, and then planning in a coordinated fashion using basically standardized protocols to promote patient health and moving things along. It advocates for co-management and teamwork. And discharge planning basically starts at admission, not after surgery. It's critical to have this kind of coordination. And then one final model, that this one has been around for a bit longer and has matured over time. This is the American Geriatric Society's Co-Care Help Hospital Elder Life Program. And it's a comprehensive program to prevent delirium and functional decline in the hospitalized geriatric patient. And again, it's driven by principles and protocols, and it targets 6 risk factors using non-pharmacologic interventions. It engages elder life specialists and elder life nurse specialists and geriatricians. And it has already been shown to translate into cost savings, $1,000 per patient over a year, or 10,000, excuse me, per patient over an encounter, and then 10,000 per year for individual patients in long-term care settings. So the overall goal is to improve outcomes and improve patient and family satisfaction, and to provide support for nursing and enhances their retention. Obviously, it also promotes the institutions who participate in such programs in the eyes of the public, and there is greater community recognition when outcomes improve through participation in these programs. So the American College of Surgeons, under their geriatric surgery verification programs webpage, has a list of all these websites, and links are available readily. Please feel free to visit them, and they're readily available to all of us. We don't have to be ACS members to take advantage of these resources. So I hope I didn't talk too fast, and I will be available to discuss things at the panel. Thank you so much.
Thank you very much, Dr. Parham. I don't see any questions in the chat. So if there aren't any, we can certainly go on to the next set of speakers. And then if anyone has any questions that pop up into your mind as the next speakers are speaking, please include those in the chat. So I think we'll go on then. Oh, here we go. There's one. From Dr. Eibling, is the communication model you presented being taught to surgical residents? If not, how can we start?
Well, that's a great question, Dr. Eibling. You know, honestly, I just learned about this communication model at this spring's American Geriatric Society meeting. So although Dr. Schwartz has been working on developing and maturing this over the past few years, it is still a very new concept. And it's just starting to become, get embraced by others. So this is the very early phase, but I was very impressed by the amount of thought that she had put into this. And I did try it very recently in one of my patients, a 90-year-old undergoing thyroidectomy, and it's very effective in decision-making. And we can talk more about it in the panel, but it's a brand new concept, and I certainly will be teaching it to my residents.
I think this would actually make a great panel for SUO and OPTO, for the Society of University Otolaryngologists, and for the Otolaryngology Program Directors Organization, to do a panel on this type of communication, the need to teach these kind of specific aspects of communication as they relate to our geriatric patients. I think they would be very helpful to educate both program leadership and to provide a model so that people can then take that back to their own programs.
Totally agree. Thank you.
All right, thank you. We'll move on then to our next speaker, Dr. Tulunay.
Hi, everyone. You can see my screen, I hope. So I'm Tulunay from Arkansas, and I will be talking on the preoperative workup of the geriatric patient. I have no disclosures. So we've just all talked about how important it is to now understand and learn about the geriatric patients, who certainly are not just older adults. They do have unique needs. And you know, we've been harping on why it is so important to understand them, because they are increasing in numbers. Currently, the 15% of the US population is over 65 years old, but they account for 40% of all inpatient and 30% of all outpatient surgical procedures. And we all know that this number is going to just continue increasing. The baby boomers are turning 65 and older since 2011. And we are going to see more and more of these patients in our clinics every day. The timing of their procedures usually tend to cluster at the end of life. So it is our duty actually to provide an accurate estimate of surgical risk if we're going to be giving patient-centered care and involve them in the decision-making. And if we're going to obtain, you know, good informed consents from them and their families. The same trends are obviously seen worldwide. We are all aging. In England, between 2006 and 2007, there were 1.5 million people over 75 who were getting surgeries. And by 2014, this number was already 2.5 million. And nearly 30% of this was in patients 85 years and older, so the oldest old. And why is it important? Because we know that postoperative complications in older adults remain a significant risk of increased costs, increased length of hospital stay. We've discussed these already, as well as patients suffering and distress. It has been noted by Coe and friends that 7% of older patients having non-cardiac surgeries experience at least one postoperative complication. And these complications usually occurred within the first 30 days of the procedure. And if you were 80 years or older, 20% of these patients had one or more complications, as opposed to the patients who are less than 80 years old. And I think Dr. Parham just said we are, as a specialty, maybe slightly behind all of this. So I just kind of wanted to include certain common concepts that we need to be very aware of, and we need to incorporate to our daily practices. I think the most important one, which I'll be talking in more detail about, is frailty, which is a geriatric syndrome characterized by multi-system physiological decline, which hence results in increased vulnerability to stressors and adverse clinical outcomes. So another really important one is functional reserve, which is the remaining capacity of an organ or the whole body to fulfill its full physiological activity. And I don't know if anyone remembers, what happened to Joan Rivers, but I think that's such a good example or a case showing how important functional reserve is. She was having a straightforward EGD, which ended up with a laryngoscopy, which ended up with a laryngospasm, which if she were younger, maybe she could have been okay with and they would have saved her. But, with her less functional reserve, she ended up having a cardiac event. So no matter how good your older patient looks, you have to remember that their functional reserve is just not going to be as someone who's 20 years younger than them. Sarcopenia is another concept we all need to be aware of, which is characterized by a loss of skeletal muscle mass. As we know, after 30 years old, we all start losing muscle bulk, 3% every year. So our older patients just don't have the same functions. So frailty, I said I will talk a little bit more about this. I think this is one of the most important concepts we need to be aware of. It's a biological syndrome, and it's characterized by decreased reserve and diminished resistance to stressors. Hence, surgery is a big stressor for our older patients due to cumulative declines across multiple physiological systems, and this results with vulnerability to adverse events. It is emerging as a better predictor of mortality and morbidity than chronological age. We all know that 80-year-old is not an 80-year-old, there's definitely a big difference. A 65-year-old might be less healthy compared to some of our 70-year-olds now, because we are operating on patients who are older than 90s. I just did one last week on a 91-year-old. So patients of the same age do not all have the same risks, but the identification and assessment of frailty may really help us identifying the vulnerable surgical patients. Hence, then we can discuss the appropriate surgical management. Maybe it is not general anesthesia, but it is sedation. Maybe it is no surgery at all. We need to be able to identify these patients. And unfortunately, there's no standardized measurements. There are more than 20 different frailty instruments if you look at systematic reviews. I kind of wanted to explain this a little further. There are mainly two models. The phenotype model, which was described by Fried et al. It looks at decline in lean body mass, strength, endurance, balance, walking, performance, and low activity, which, if you think about it, are all things that are very straightforward and easy for us to assess when the patient comes to clinic. We already do this. Sometimes we just don't document it. So if patients have 3 or more of these 5 features, they're deemed frail. And I'm going to go into how we can assess this pretty easily when we are seeing our patients. And if they have 1 or 2, then they're pre-frail. The second model is the model by Rockwood et al. And this is the frailty index. and it is a cumulative deficit model. And this really stems from the Canadian study of health and aging. This is an exhaustive study, and I think if you're going to read, some of their papers, this is definitely very useful. This model conceptualizes aging as accumulation of deficits. And so they measure, on top of what we talked in Fried's methods, nutrition, comorbidities, but also very importantly, functional status, disability, and mental health, so cognition. We can't emphasize the importance of assessing the cognition in the older patients. And then there are many different models that have stemmed from the frailty index, such as the deficit assessment index or the Johns Hopkins one, and then the modified frailty index 11, which I'll talk a little bit more about. So the frailty index is a very comprehensive method of geriatric assessment, and it is essentially calculated by counting the number of deficits divided by the number of deficits that are measured. So where is this coming from? It's coming from the comprehensive geriatric assessment, which really is the gold standard of assessing a geriatric patient, but it is very exhaustive. So the CGA is a multidimensional interdisciplinary diagnostic process, and it's focused on determining if frail older persons, not only medical, but also psychological and functional capabilities, in order to come up with a coordinated and integrated plan for their treatment, but also for their long-term follow-up. And you can see the number of factors that go into a comprehensive geriatric assessment. It is both a diagnostic and a therapeutic process. Unfortunately, it is very cumbersome for us to be able to use in our daily clinics. But this can be done as an outpatient by specialized centers, as well as specialized inpatient wards. And if you look at some of the studies, that's probably the best way to go, but not possible in every patient. So what can we do in the office then, if we're not going to be able to do all these cumbersome techniques? Here's the modified frailty index. Sexton and Vilanovich are the first ones who came up with this, and there's a lot of studies in our literature, especially from the head and neck world, that has validated this. It looks at 11 items that have been drawn from the actual frailty index. And if you look at these, we do use all of these, and we do document all of this in our charts. So this is pretty easy for us to be able to gather. The next thing, we talked about frailty, and one of the factors that played a big role was weakness. So reduced muscle strength, which can be measured with grip strength, has been associated with increased risk of all-cause and cardiovascular mortality. Grip strength testing with a dynamometer is actually a pretty simple, quick, and inexpensive means of stratifying an individual's risk for cardiovascular death. I actually just ordered one online yesterday for my clinic. I'm going to use it in my swallowing patients, but this is a pretty straightforward thing. It only costs a couple $100, and you can easily employ these in your patients. So weak hand grip strength in later life is a risk factor for disability, morbidity, and mortality. And it is a very important part of our description of sarcopenia and frailty, which we're trying to assess in these patients. So this might benefit you in order to select the patients who might really need a closer clinical attention. And we've already discussed how important the role of our geriatrics colleagues are. So these are the patients you're going to screen and maybe select for further evaluation. The other one is very simple again, the Get Up and Go test. This is where you have the patient sitting in a chair. You're going to tell them to get up, hopefully without using the arms of the chair, walk 3 meters or 10 feet. There's going to be a marked point on the ground, and then they're going to turn around and come back and sit. They should be able to do this less than 15 seconds. And if they can't, this has again been shown to really speak for their functional reserve and outcomes during surgery. So here are just 2 easy things to be able to do in clinic that can guide us. So frailty has been noted to be, closely correlated with 12-month mortality, but also it is associated with increased 2-year mortality, increased postoperative complications, It is there's an association between frailty and major cardiac and cerebral events, as well as discharge to residential care facilities, which we talked about the importance of that, if possible, preventing it, and as well as decline in quality of life. So obviously it is very important in our perioperative planning, not just for preoperative, but also, as Dr. Eibling will talk, postoperative care as well. But for it to be an easy assessment for us and for its value to be utilized, it has to be easily incorporated into our routine assessment. And we ideally should be able to create it from existing information. And I think with, the modified frailty index and other measures, we've showed that this is definitely possible. I think this all comes down to us documenting as opposed to just observing some of these and not ever, these things never getting into the charts. Another very useful tool that I think it should be in our toolbox is the American College of Surgeons Surgical Risk Calculator. This is again a decision estimate making tool. Essentially, it estimates the risk of 12 30-day outcomes using 21 preoperative risk predictors. And Horner et al. In their recent study have taken this a step further, and there's the development of a geriatric specific risk calculator. And this is through the NISCUP data from the American College of Surgeons. And you can see the 21 traditional ones, but also the 6 added risk factors for geriatric patients. And these are things which we ask, like fall history. This is taken by the nurse automatically. I'm guessing in every clinic across the states now, that's a question that is asked. Use of a mobility aid. We already observed the patients coming in with that, and we've already talked about the importance of cognitive impairment, and I know Dr. Eibling will be talking about this further. So it has been shown that out of the classical ones, these are the ones that are really important for geriatric patients. Functional dependence, I want to emphasize that, as well as age, of course, and then the type of surgery that they're going to have. And in terms of the 6 geriatric specific variables, the strongest risk factors were the impaired cognition, fall history, and mobility aid use. If a patient is coming into your clinic with a walker or in a wheelchair, it helps to document that. Another really nice tool to use, which has been, now this is the version at the VA hospitals, is the Risk Analysis Index. And this has been validated through multiple studies throughout the VA system. And again, it looks at the similar types of deficits that the patient carries: unintentional weight loss. I get a very detailed nutritional history, but maybe my colleagues who do rhinology don't do so much. It is very important for the older patient for sure, as well as some of their comorbidities such as renal failure, congestive heart disease, and obviously pulmonary status. But we all see that the new paradigm is collaboration and interdisciplinary work. It's very important to recruit our geriatrics colleagues in helping us with these patients. I think there is a trend towards this, certainly from Duke, and also I'm sure Pittsburgh and some other big centers have already reported significantly on the importance of doing this early on. And then during the hospital stays, involving the geriatricians early on in these patients, such as the free flap patients. And this shows significant reduction in the rate of post-op complications, such as delirium. Again, this is how we need to be focusing on our patients at this point, is to incorporate geriatric medicine providers early on with the care of our patients. And then Dr. Parham mentioned this. I think if you're going to read just one thing, this is probably one of the best articles to read. It has really very useful recommendations for all of us. I'm going to just touch upon a very few of them. Cognitive impairment and dementia document, because if there is a change, after the surgery, it may be very difficult to assess this, especially if there is no patient family around and you're relying on caregivers from a nursing home. So document the cognitive status prior, and we already discussed it's not just the documentation, but further assessment of this for many reasons. And this is something that should potentially trigger further geriatrics assessment before the surgery. It is also going to significantly affect your planning. So I think one of the most important factors other than frailty is really the assessment of cognition, because even sedation, as we talked, or general anesthesia is going to significantly set a patient back. I mean, I've had the patients with dementia that has to be discussion with the patient and family on whether or not having the surgery is really worth the risks of it, especially for elective procedures. And this also helps assess the postoperative course and the risk of delirium. So it is increasing. I mean, 22% of the patients in the US older than 70 years old have cognitive impairment, and 13% dementia. And this number is just only going to exponentially increase. So we're an aging population, medicine is improving, we are living longer. So we're going to see more and more of these patients. Ideally, these discussions should be happening with their primary care doctors and caregivers early on, what their wishes are and what they want when they can't really tell us that. But we are going to, even though we're otolaryngologists, we're going to be doing these discussions more and more with time. So it is pre-existing cognitive impairment strongly predicts post-op delirium and worse surgical outcomes, longer hospital stay, and mortality. I'm not going to go into this because I know Dr. Eibling will be. The other one is pulmonary risk factors. If you look at this, obesity is not necessarily the most important one. It is other things such as age, chronic obstructive heart disease, ASA scoring. I think we are all familiar with ASA scoring, which is again a very useful preoperative tool for us to do at the VA hospital. We have to do it automatically on every patient we're sending to the surgery. So functional dependence and also cognitive impairment and impaired sensorium, which, you know, all of these indexes that we've just been through kind of use all of these same types of factors that are easily seen in our clinics and should be documented better and discussed with the patient in more detail. You know, we do have to spend a little bit of extra time discussing this, but it is going to essentially make significant improvements on our postoperative outcomes. And of course, prolonged surgeries, you have to discuss the risks of general anesthesia on the lungs. And this is sometimes a reason why we do in-office procedures, or I mean, if they have significant risk factors and I'm not comfortable doing it in the clinic just because we're so far from, you know, anything, if anything happens, because I'm not in the main hospital, I'll take them to the operating room, but I'll just do it awake still. So I'm monitoring them better, and there is an anesthesia team around if I need something or if the patient experiences an adverse outcome. Nutritional status, I mentioned this briefly. For me, it is very automatic just because I see dysphagia all the time and I just take a very detailed history, but we cannot emphasize, I mean, I can't emphasize the importance of this because this already, if there is a big nutritional deficit, you're already starting behind on the healing. So you need to document this, and this is where we can intervene earlier with rehabilitation programs such as it was discussed. So unintentional weight loss should be a trigger for us to assess that further. Polypharmacy, again, you know, it's very easy to just click a button on our, you know, Epic or at the VA, say medications reviewed. You really do have to review them because you learn so much from that, and there's so much you can prevent by actually going through that list and discussing it with the patients. On anticoagulants, I think is a most, you know, is a given for most of us. We automatically do that, but there are other medications there that you have to really pay attention to when you're planning for surgery. And then, you know, when you have a new person just come helping you run your clinic, I think these are very common questions, like which test do I order? Do I order everything in the book? Do I order just some labs and not an EKG? This is the recommendations from the group, is that hemoglobin should be ordered pretty much for everyone, renal function tests, and serum albumin. And I tried to do a study looking back when I'm interested in sarcopenia, so I was trying to review charts and draw some of these results, and we don't order albumin routinely in most of the patients. But if you have a patient undergoing major surgery who's older, or a patient who you think might have malnutrition, you need to order these. So I think that's one that doesn't get ordered routinely. Chest x-rays, again, more, older patients, more than 70 with a history of lung issues. A patient that might have a possible ICU stay, such as head and neck cancer patients, or any patient undergoing major surgery needs a chest x-ray. Same thing for the EKG. Anyone who's going to undergo an intermediate risk surgery should have an EKG as baseline. Of course, we're going to order that for any patient that has known heart disease. And with this, I would like to thank everyone and would be happy to answer any questions if there is.
So there is a question. Let's go ahead and just ask the questions before we get to Dr. Eibling, just since your presentation is fresh in our minds and we did not have a lot of questions earlier. So there are two. One, do you engage the geriatrician in the care of most elderly surgical patients for the purpose of frailty assessment, or do you perform your own screen to establish who needs geriatrician input?
So I wish I could involve geriatricians on. I think the ideal is to involve a geriatrician, not for every patient, but for those. I think the useful tools are the screening tools, such as the grip strength. If you're documenting weakness, if they come in and they look frail to you with, they're walking with a walker or with the assistance of family, they can't even transfer to the chair. If they have nutritional deficits, and if they're going to undergo major surgery, then I think, we should do a preoperative geriatrics consultation. Does every patient need it? I don't think so. I mean, I have 75-year-old patients that are healthier than a lot of my 50-year-old patients. So if they are positive on the screening tests that we just mentioned, then I think we should. And I think the Modified Frailty Index 11 can be very useful, because we already look at all those data points when they're in our clinic. That's just there. We just have to really look at it.
Thank you. And then there's another question. How does the American College of Surgeons model for assessing potential outcome relate directly to otolaryngology procedures? Is something like neck dissection already included, or do you have to extrapolate from what is the most similar general or vascular surgery procedure included on the outcome scale?
Unfortunately, some of these we do have to extrapolate. So there you just find something that is close enough. And unfortunately, otolaryngology is not in all of the CPT code risk assessment factors, especially at the VA. Most of the times there isn't any ENT related procedure.
Okay, thank you very much.
Thank you.
Dr. Eibling, take us home, David, for the specific focus on delirium. And you are still muted. There you go.
Yeah, there we go. I think I'm unmuted now. So you may have noticed a little log on the bottom of Dr. Parham and Dr. Tulunay's slides. That's the American Society of Geriatric Otolaryngology. Dr. Parham is the current president of the organization, and Dr. Tulunay is a past president. I am too, but I'm sort of the geriatric otolaryngologist of the Geriatric Otolaryngology Society. So I'm well past the cutoff for geriatrics. I'm almost to the point of being involved in the verification program. So I'm going to basically discuss something that we've all seen. It is something that really, I think, makes us all a bit on the crazy side, because oftentimes it catches us unawares. I have no disclosures. I'm not going to talk about any off-label use. I have no secret sauce. And not only do I have no secret sauce, I have no amazing new discoveries. But there is a secret sauce, and the secret sauce is to collaborate with others in your organizations to set up a program. And this is not something you can sit down and read one day and decide, oh, I'm going to start doing this. You really need to get a group together in your organization. So if we do nothing else tonight but stimulate you to say, aha, this is important. Let's do this in our organization. And let's get together a group of people. Here are the resources that we've heard about and that we can find online, and we can employ this for the benefit of our own patients. And I think the other disclosure I have is that although we know a lot, there's a lot that we don't know. So I'm going to try to answer some questions. One is the impact of postoperative delirium. You've already heard that, actually. And then how do we respond? And then what can we do to reduce this impact? And you actually have already heard this from our previous speakers, and that is assess risk. And then with the goal of reducing the incidence and severity and duration, and then to try to manage expectantly, and where can we turn for guidance? So this is an interesting factoid that I discovered when I was preparing for this presentation, and that is in the American Geriatric Society Geriatrics for Specialists Initiative, which actually Steve Parnes and who's on this call as a participant, and Karush, and I think several other people on this call were involved in that GSI program some time ago. And in the survey, one of the things that rose to the top was that the delirium, post-op delirium, is the most essential issue. Now, I have to point out this is prior to the recent emphasis on frailty, but nevertheless, we've all been there and we know that this is a problem. The other thing that's really frightening is that perhaps 40% are preventable. And what does prevention mean? Prevention means identifying who's at risk and then making decisions in the perioperative and postoperative period to reduce the likelihood of postoperative delirium becoming a problem. This fact that it's preventable actually says that we have a lot to do, because what that means is that that 2 out of every 5 of our patients who develop delirium would have been able to avoid delirium if, in fact, we had followed some of the basic tenets of assessment and prevention. And here's the other scary thing. There's hypoactive, hyperactive, and mixed types. So when we think of delirium, we think of the hyperactive geriatric patient who's pulling their tubes, who's trying to get out of bed, who's trying to run down to the parking lot, or as my own father did, make it a couple miles down the road in Mobile, Alabama, in the middle of July, trying to go home, forgetting that home was 25 miles away. So that's the hyperactive type of delirium. But what is much more common is the hypoactive. And we miss that a lot because we have not built into our systems a standardized way of looking for delirium in our postoperative patients. And as was pointed out by previous speakers, assessing cognitive decline going into a procedure will help us identify those likely to have cognitive changes afterwards. And the other thing that we've heard before is that there's a strong correlation between short and long-term impairment of surgical recovery. So this is the official definition, and this acute, altered, fluctuating mental status. And this is different than alcohol or benzo withdrawal. In fact, if you read the guidelines, they point out that the treatment with benzos, the recommendation not to treat delirium with benzos does not apply to alcohol or benzo withdrawal. And of course, how do you know about that? You have to ask the question. I put a question here about nicotine withdrawal. I have my own personal beliefs. Some of you may have other beliefs, with something we could look at, discuss in the panel discussion, perhaps. There's also very, very good association with postoperative long-term cognitive dysfunction, which is different than delirium. Okay, so long-term memory changes and changes following surgery, which are a real thing, seem to be different than postoperative delirium, but are associated with delirium. And then dementia. So dementia increases the risk of postoperative delirium, but delirium is different from dementia. So there's some scary stuff about long-term cognitive decline in association with the postoperative delirium. So here's a group of 88 patients, of which 46, I guess, were followed. And of those, something like a quarter of them developed postoperative delirium. And the ones that had delirium were, in fact, an average of 4 years older than those that did not have postoperative delirium. And then they had a post-op phone or face-to-face visit between 2 and 3 years later. And what they found is that more than a quarter of those that had postoperative delirium had reduced activities of daily living, ADLs, in their long term. This is not like 30 days. This is 2 to 3 years after surgery. Now, you could say, well, is this association with other comorbidities, or is it causation? And clearly, when you read the literature, it becomes apparent that many authorities believe that there is a causation. So you've already heard a little discussion about the AGS clinical practice guideline, which was published in 2015, and served as the nidus, if you will, for the programs that followed. And it addresses primarily treatment guidelines, and it assesses the risk factors. Well, interestingly, the risk factors, as we've heard about, there's no surprise. And we know all of these things. And you realize that many of these you can detect by history, but many of them require more than history, which is where having a program that is going to do the mini-cog or assess strength, or assess whether or not the patient has had prior significant difficulties. And if you look at this list, you realize this constitutes a great percentage of our older people on whom we are contemplating surgery. So in the new program in the VA, it's termed the surgical pause, PAUSE. And the new program is using the RAI, the risk assessment index, to ask the question, do we need to take a step back for this patient? And much of what we've heard already suggests that the data is oftentimes there. It's a matter of putting that data together into a framework that says, wait a minute, this is somebody we need to go back and ask the question again. So what are the risk factors that occur in and associated with the procedure? Well, the duration, the complexity, the approach, cardiopulmonary bypass, and I'm going to mention a little bit about this EEG stuff, as well as the association with anemia is well known, intraoperative blood pressure, and probably glucose control too. So this is now a strong recommendation from the clinical practice guideline for treatment. So now I've gone past assessment, and now what I'm going to do is talk about treatment. And the big emphasis is really on non-pharmacologic intervention. And we're going to talk a little bit about that a little later on. But this is really a bundle. And it's a bundle where a multidisciplinary group sets up a program to try to prevent and to manage delirium should it occur. And then this idea that many times patients with medical illnesses may in fact develop delirium. So it means looking for what are the medical causes. Pain management, patients with pain, older patients with pain may in fact present with delirium. And then avoidance of specific classes of medications. And you recognize that most of these are right out of the Beers criteria, if you will. In other words, avoiding anticholinergics, avoiding benzodiazepines, and they make a specific recommendation to avoid antipsychotics in the hypoactive form of delirium. And I'm going to talk a little bit about more of that in a few minutes. So they point out that a bundle, though it's a weak recommendation because of data, of outcomes data. As we heard Dr. Tulunay mention this concept of regional anesthesia or local anesthesia for procedure and for pain control. And then utilizing antipsychotics, i.e. Haldol, essentially, for the hyperactive delirium in which the patient is putting themselves at risk, and that these should be administered at the lowest effective dose. Now, interestingly, if you talk to your critical care team, et cetera, you may hear that there's data that in the New England Journal, this is from 2018, that there was no significant effect of Haldol or this paradigm, which is one I don't know. And so this is interesting. And wait a minute, well, this doesn't match clinical experience, and it doesn't match the guideline. Well, I think if you look at the paper, you find two things. Number one is that as I mentioned before, hyperactive is more uncommon. And in this particular group that studied that was assessed in the New England Journal paper, a little more than 10% had hyperactive delirium. And they didn't actually split out the data. And then my pharmacy colleagues tell me that the dosage that they used was somewhat lower than what is oftentimes used. So this is another resource that you might find very interesting. I circled Timothy Miller, who's actually from Duke, and one of the leads in this particular review that was published 1 year ago this month by an anesthesiology group looking at preventing post-op delirium. And if you read this list of names, this is like a who's who of delirium in the anesthesia world. And there's something like 222 references. And no, I made no attempt whatsoever to go over those references. And the themes are the same. And to make this easy, I separated into pre, intra, and post. And so that's supposed to be blue, red, and green. So the prevention begins with assessing the risk. And we've heard a lot about that already, assessing cognition, looking at their medical history, looking at their current medical status, looking at the indices of frailty and a variety of other situations, such as, for example, their medication list. And then they make the point of discussing this with the patient and the family. In other words, a la the communication discussion that we heard from Dr. Parham, that a discussion with the patient and the family that regarding what is the probability or what is the likelihood or what are the chances, if you will, of postoperative delirium being a problem. and then in the prehab world, correcting what is correctable. But it begins with first assessing. And as you are well aware, we frequently take people to the operating room and miss things that are really significant, such as, you know, we find out after we operated on them that they in fact had a history of cognitive issues which were kind of vague and not recognized as such by either their family or their care providers. And then avoid or minimize high-risk meds, intraoperative, and I'm going to talk a little bit about that in another page. And then postoperative, look for signs. In other words, how do we develop systems where we actually assess our post-op patients for the development of delirium, manage their pain, and then minimize high-risk medications, and then employ a non-pharmacologic bundle. So this is sort of the non-pharmacologic bundle. And as you heard Dr. Oslam, Dr. Tulunay point out that if they're weak and they don't get out of bed, they're more likely, if you will, to suffer from delirium. Getting up, seeing the world in an upright position makes a difference. Give them food and liquid. Again, if they're hungry, they may not be able to tell you that they're hungry or that they're hypovolemic, but they give them food and liquids. Review their medication lists, and this is a constant theme of all of these guidelines. Look at the medications they're on, look at medications that might be precipitating delirium, manage their pain, facilitate sleep. And I'm guessing many of you work in facilities that have like quiet hours, quiet times, where they turn down the lights and let the patients take an afternoon nap. Just a little aside, when I was a resident many years ago, I would characteristically walk through the hospital in the middle of the night whistling to keep myself awake, and they passed an edict there would be no whistling in the halls of the hospital in the middle of the night. And of course, I realized it was about me they were talking about. So the patients do need to sleep, and give them back their hearing aids and their glasses. I can tell you, when I take my hearing aid out, the whole world sounds muddy. It just sounds like mud. And give them back their hearing aids and give them their glasses. And then remind them of reality. And you've seen that on the wall, on the walls, you know, the calendar. Today is Monday, June 14. It's Flag Day, by the way. I got my flag on, you can see. Remind them of reality. And then to the extent possible, and realizing, of course, that this may not always be possible in the world that we live in with tubes and free flaps and other associations, try to minimize physical restraints. And these are all in this little circle. This is right out of that anesthesia review. So the review actually addressed anesthesia depth, and it was interesting that there was somewhat of a controversy. And the idea is whether or not doing BIS measurements during surgery make a difference. I actually asked the anesthesiologist on the case I did last weekend what they thought. They said, oh, it definitely makes a difference. But it turns out it's somewhat controversial. So your anesthesiologist probably is aware of the controversy, has a strong feeling, and you need to know that there's another anesthesia consensus panel working on that now to assess whether you can affect postoperative cognitive changes with this. So this is my last slide. And I don't expect you to read this, because what this really is a, if you will, a synopsis of what we've just been talking about. And then the risk factors, we know what those risk factors are. Their age, their previous dementia, known cognitive decline, anemia, substance abuse, and we know that there are things that we can do to reduce the chances with trying to reduce the use of sedative medications when possible, particularly the benzos, enhance their sleep, try to maintain their vital signs in a stable condition, and return their senses. And then again, in the history, we can then identify risks. And if they develop delirium, we ask the question then, is there an organic cause? Is there electrolyte imbalance? Are they septic, hypoglycemic? And then if we can find the cause and we fix it, well, that's good. If we can't find a cause, then this non-pharmacologic management a la bundle, again done with in the format of a cooperative group in an organized, systematic fashion in the postoperative period. And if necessary, then institute sedative or antipsychotic medication. And in this particular paper, the Haldol was the choice. So that was my review. And as I said, no secret sauce. But I hope I've given you some ideas of where to go from here. So I'll turn it back to Liana, Dr. Puscas.
Thank you, Dr. Eibling, for that very informative discussion about delirium. I've been monitoring the chat. I don't see any questions, but if anyone has any questions, you can put them into the chat. I will say that I think people are more aware of the need to give people back their hearing aids and their glasses. I think hospitals are making more of a concerted effort. I know that we are at Duke to do that, and at the Durham VA as well, because I think we've realized that if you can't see very well, and certainly if you can't hear very well, then it just makes communication that much more difficult. It makes comprehension that much more difficult. People feel an increased sense of isolation, which I think in the COVID era has been even more magnified because you really need to have some kind of a smartphone or some tablet or something to be able to communicate, since visiting hours are much more restricted than they have been. I mean, we're slowly getting back to a more normal visiting hour schedule, but it's still not close to what it was, although it is certainly better than it was a year ago. But I think those are really important points to make about people being able to communicate with others and how that helps to avoid some of the problems that we see with delirium.
So I want to ask a question of Karush and Dr. Lagoo regarding how do you start a program? I mean, how do you go from, oh, this is a good idea, we need to do it. How do you move forward? And I know you folks have been actively involved with that for, I guess, over a decade, I believe. How do you make that happen?
I'm going to give a quick answer and give you the perspective of a not so successful effort, and then maybe Dr. Lagoo can give you an example of a very successful effort. Here at University of Connecticut, we've been trying to get the geriatric surgery verification program off the ground and participate. And we've been meeting with challenge after challenge in terms of coordination and resource allocation. It does require some resource allocation up front. It does require commitment. And to bring in our leadership to buy into that has been a bit of a challenge. And there are turf battles to fight and overcome. So we have not been able to join despite the strong level of interest. So I'm sure Dr. Lagoo can tell you what it took. And she gave many examples, many convincing sets of data and financial benefits to the institution for participating. But to assert that still requires another level that here at UConn we haven't been able to achieve. Sandhya, you want to comment at Duke how you guys succeeded?
Sure. So I think in the words of Mitch Heflin, one of the geriatricians who has been my partner from the beginning, it was a lot of blood, sweat, and tears. The money comes much later, and it may never come at all. But I think it's amazingly possible to get a community of people from all the different disciplines. We got champions initially from just 5 surgeons, and they just happened to be surgeons who were all in GI surgery with offices right next to mine. So I could talk to their nurses, I could talk to their secretaries, and make sure that patients that they were scheduling for surgery, they would inform me of those patients so we could look up who are the ones who were frail. We then came up with a list of trigger factors that we shared with all the surgeons outside of this small group of 5 surgeons, and said, if you have any of these trigger factors in your patients, call us. And we were always available. So it was difficult for a geriatrician, you know, sometimes just like for a surgeon, somebody calls you and says, we have this case for you, it's 7 o'clock, you're busy the rest of the week. You don't know whether you can do it, but you say yes. And our geriatricians were amazingly helpful. And this is true about all the other specialties that were involved. The amount of interest that they had, and I talk about the nurses from the floors. So always look for nurses who have done either the niche program or the ECHO program at the VA. They have had geriatric training, make them the champions on their floors. They are more than happy to help. So that was one of the things that we did. And then the other thing was really reach out to all the departments and to the chairs of the departments to say, we have this program. If you would like us to share this program with your faculty, we'll send you all the information. Please share it. And you know, it'll be 10 years next month since we started the POSH program. And it is an evolution. It's an iterative process. But I think getting people in every group interested, involved, is the key thing. And once you do that, then like creating a geriatric surgery verification program, whether you go through the program or not, you're still able to share that wealth with everybody. And Dr. Eibling mentioned really well, I mean, as far as delirium is concerned, when we started the program and did our initial study, the paper that I showed you, we found that the incidence of delirium in the control cohort was 5%, and in our POSH cohort, it was 25%. And it was very distressful to see that result, but it was really because our nurses, our physical therapists, the pharmacists, and all of our residents, they were looking for these signs of delirium and were able to diagnose delirium much better than in the control population. That's why it was 5% and 25%. So I think getting everybody involved and the families, we request the families to actually come to the clinic appointments and get a lot of information from them. Again, as was mentioned before, the patient's family telling you that, oh, he's had this problem with delirium in the past. It may not have been called delirium, but they tell you. So just get all of these people to be your champions as you move forward. Sorry, I didn't mean to say so much.
No, I think it's great. I think that the take-home message from what you just said is that you have resources that you can marshal, even if you don't have a particular program, and that the geriatric surgery verification program, although it's very formal, you know, it did start out as that POSH program where even if you can have something organized with even some clinic visits on the same day, you know, even that makes a big difference. So that can really help people. I did want to summarize some, oh yes, please,
I just
Aslan.
wanted to correct one thing. The NSQIP ACS risk stratification does have ENT surgeries included. And at the VA with the RAI, it has been a little bit more difficult. And then one thing about these types of risk stratification you know, instruments is that you have to enter the correct data. What we've noted is sometimes, you know, the people entering, and you're going to recruit some people to help you with these sometimes in clinics, such as your nurses or your residents. If you don't, you know, select such as mobility, that makes a huge difference on the risk assessment or the ASA scores. You're just not going to get the correct data. So I think it just is being a little bit more cautious. I wanted to correct that.
Thank you. I wanted to take just a couple of minutes to review some of the highlights from our speakers. So I want to share my screen. So this should work. All right, so you all should be seeing my slides. Oh, I'm kind of in
Yes.
the middle. Okay, so I just wanted to remind everybody what the CME code was. You can text this to that number, and if you have problems, you can email Lori Alsbrook. She will be sending out a survey tomorrow to assess your comments. I'm sorry, your comments on the program, and see what we might be able to improve for next time, because we certainly would like to do this again in about 6 months' time, and there'll be more information on that. So I wanted to just highlight from the Geriatric Surgery Verification Program sponsored by the ACS that the 4 major areas are those of goals of care and decision-making, the cognitive screening and delirium prevention, the maintenance of function and mobility, and nutrition and hydration optimization. There are over 30 standards, but they fall into these 4 areas. And so even if you can't do the whole program, these are the areas that you know are important in this treatment of geriatric patients. The various standards outline processes for systematically improving the communication, the screening of the patients, the management of the medications, providing the geriatric friendly rooms, and as we just heard about the specific things involving returning eyeglasses and hearing aids to patients, and then of course ensuring that proper staffing is in place, especially with nursing, to ensure that they have appropriate training in the care of older adults. Once again, the issue of cognition, you'll see as a highlight, because it's very, very important that we establish a baseline assessment of the patients. The communication framework for communicating with the geriatric patient and his or her family is really important, because there must be a clear understanding, depending on the level of dementia and the level of engagement that the person has in their own healthcare. Their power of attorney, their child might be performing more of the decision making than you might typically expect for an adult. So it's very, very important that the communication is very clear amongst everyone in the room. And then the importance of remembering to act on what matters to the patient, assessing their medications, assessing their mobility, and assessing their mentation. I think that those 4 M's, it's a really nice mnemonic for being able to remember those 4 significant areas of unique need within geriatric surgery, and that adherence to some formal program, either the ACS, geriatric surgery verification, or other protocol, will improve your outcomes, as we had just been discussing. In the perioperative management phase, utilizing geriatric consultation for specific assessments of needs that you have identified in your patients can help very much in managing these patients. Consulting the geriatrician early to identify issues and develop a plan is very important, so that you can stay ahead of problems instead of having to react to them. Involving the primary care physician in the pre-op assessment is very important, as hopefully they've had a longer term relationship with their primary care physician, and that person may be a very valuable resource in helping to identify problems and treating them. Frailty and lack of reserve are 2 major factors that contribute to complications and outcomes in the older patients, and both of these need to be assessed. The Modified Frailty Index is a validated and concise assessment tool that we as surgeons can use without having to resort to much more time-consuming indices out there. And then the clinical practice guidelines from the American Geriatric Society are extremely helpful. And once again, assessing for cognitive impairment, that has to be stated over and over again. And then in the specific area of delirium, we need to remember that this is the most essential issue facing the surgical care of the older adults, but that about 40% of it is preventable. So we can identify etiologies and we can treat those etiologies for the delirium. Patients need to be assessed, and the patient's family and caregiver need to be involved in discussions so that they know what to expect postoperatively, and that we need to avoid certain medications while still achieving pain control and comfort for the patients. And this is again where the geriatric consultation may be of use, or the anesthesia pain service, so that we can have a multimodality treatment option for these patients. And then just to mention, just for completion's sake, about using Haldol only for hyperactive delirium, I think that perhaps many of us might remember from residency that Haldol was used a lot more frequently, but I think we've seen that there are some reasons not to do that, and that it does have a role, but typically only as a last resort, and only in those who are hyperactive in their delirium. So I wanted to see if there were any further questions, and if not, I would like to thank everyone for their time. It was a great panel, and thank you very much to all the panelists for the time that they spent in preparing these talks, and to all of our participants. I'm not seeing any questions, so thank you very much, everybody. Have a great evening.
Thank you.
Thank you, Liana.
And a shout out to our Saudi Arabian and Yemeni colleagues who stayed up into the early hours of the morning. Kudos to you for your dedication to learning.
Have a good
Thank you
night.
so much, Liana.
Everybody sleep well.